For anybody who has interest in kind of changing my words around in other means, this is meant to be of academic and dialectic nature only, and anything taken out of context I do not give permission for. I am an older guy. I'm not a technophobe. I really am probably not, all for development. I don't like too much radiation. I do like efficiency and precision. I'm not against this procedure. I had dabbled with it at UW. When I came over here in 2014, I was again in the company of Rod Oskuyan. And not only did he drive this cool, shiny car on the right hand as mine, his car smelled much better than mine and was much faster. But again, I have a couple of dogs that ride in it. So this is the basic premise here. I was in the company of a master, and why would I want to compete with that? Basically, any anterolateral procedures, I usually just ask him to do them because they're really, really good. So that's that. So I'm just going to very rapidly go around. Why are we kind of forgetting about doing a good job with surgery just from the backside and being maybe a little bit smart about how we dissect our muscles, not crush them with thoracotomy spreaders for hours at a time? Luis, fantastic. Absolute artwork. Always a pleasure to see you. Why don't we just...
You have a good chance to do posterior and anterior.
Exactly, and again, that's going to be the summary of my talk. But again, as we're looking at this, there are multiple ways to get there, and again, as we're trying to go through the front, there are multiple things that we have to worry about that I don't want to worry about when I do spine surgery. I don't want to think about it as a descending colon retroperitoneal, interperitoneal here. Where's the diaphragm now? I want to basically not listen to neuromonitoring people more than I already do, and certainly not some nerve fiber dissections. And again, the basic issue is that we're seeing complications now, and I sit on a central surgical complications committee that we've never seen before, like kidney catastrophes from a pretty mundane pedestrian problem where there's no more kidney there, and basically the patient now has a chronic nephrostomy. I mean, this is stuff that we never knew of before. And again, if we critically look at the literature, it does look like probably with anterolateral surgeries, there's a higher degree of radiculopathies than with posterior surgeries. This is a very contentious number, and I know there are different thresholds and definitions, but undeniably, again, the artistry of masters here plays a great role. How long are these retractors in? How efficiently are the trajectories and the manipulations that take place? Because otherwise, that lumbar plexus is going to be a problem. So again, this is a cadaver look, and this is how these things look like in the front. So you somehow have to navigate through that stuff on the bottom. And again, all these things have to stay on your mind. And just earlier today, we saw one of those fantastic things where a beautiful dissection was done by a colleague. And again, the master educator right here started getting very agitated. And the master indoctrinator right here basically told us all that we need to be indoctrinated a little bit more. So there was a nerve in front of the L4-5 disc space that led to this high level of anxiety in the whole room here. And why is it? Of course, there's a dramatic bundle of nerve tissue. In the bottom center is Perry Godolphius, one of our past research fellows, great reconstruction. One, this is a reconstruction from an actual MRI scan with 3D printer. You're weaving yourself through that stuff here. This is pretty cool what you do, if it works. But he did this out of a 3D reprint from a standard MRI scan. And this is, again, what we're trying to do here. And again, so a common thing now is that I've heard from a lot of MIS surgeons that they liken spine surgery, especially in the lumbar spine, more and more to that of a dentist practice. You don't take care of the whole failed dentition. You can just add something on it. And so failed XLIFs, like this standalone device on top, are also becoming something that I really love doing. So my subspecialty is going to veer more and more from tumor surgery and deformity surgery towards redo surgery. And for MIS surgeries, I've kind of seen a 2-year life cycle. Patients actually do pretty well, usually for 1 to 2 years, and then things start falling apart, and then there's a big midline surgery that takes place like this. So the point is, again, what can we do? And posterior surgery got a bad rap because of pain and pain management. And again, we don't have an answer for this. Doing better retraction, better muscle dissection so we don't denervate as much, learning from our less invasive colleagues clearly is necessary. But we have an unparalleled access from occiput to pelvis. And again, with our former fellow Elias's recent nice publication on the erector spinae block coming in the near future to GSJ, this is becoming an interesting potential because, again, for 1 to 2 days, we can probably really mobilize patients way better. So again, is posterior surgery really that outdated? You know what? I love Leon Wiltsey, and actually his partner, Paul DiMartino, was one of the game changers from my own career development. But I really don't like his paraspinal approach. I think that's an anachronistic approach. And I, as an orthopedic surgeon, don't know a single other area in the body where we can perforate a major muscle and say that's better than going in an intermuscular interval. I don't know that. I mean, think about your thigh.
I agree. I'm saying it every time.
All right. So, and what I really love to see nowadays are these Uzi approach patients. I mean, literally, they've been shot and perculated everything. And I'm going to just do a simple posterior midline approach. But is this an advancement? Was this patient helped with less invasive surgery? Maybe not. So again, we need to keep the muscles viable. We need to keep innovated. We need to be smart about how much and where we retract and what we really need to see. We need to be far better about our closures and incision management, of course. But a posterior-only surgery does allow an unparalleled paradigm of spine surgery. Where it's truly needed, we decompress the nerves properly, we protect them properly, we realign, we release the spine, and we do a proper posterior 3-column reconstruction through anterior column reconstruction and posterior rebalancing. And here's a spondylolisthesis reduction. Again, this is one surgery, and yes, you could argue that you could do this through 3 or 4 approaches in the front and the side and all that, but one single incision in the back, about this long, not the end of the world. And again, posterior 3-column reconstructions, if you need the whole spine, you just need to basically do the whole job. You can rebalance the spine, you can release it. This is what Dr. Skuyan earlier called the IDO, the interdiscal osteotomy. Basically, Bob Hart mentioned it also, it's an expanded PSO and a preservation of the disc spaces. You use the avascular disc space with end plate preparation and preservation, the careful protection of the nerves to basically achieve a complete rebalancing of the spine. So these are just some cases that I'm flashing through because this is quite boring and a cool lateral and anterolateral course, and I really thank Juan and Rod for allowing me to say this. But again, I just thought I'd do the following thing. I'd show you 3 cases that we just did from last week. Case 1, 2, 3, and flash those in increasing difficulty. Case 1, simple degenerative disc disease. Case 2, a little bit more complicated circumstances. Case 3, these were all done this last week, so no long-term follow-up. Case 1, rancher, multiple discectomies, 5-1, 2-3, 1-2, not a clinical problem. A really cool guy, multiple injections, radiculopathy, low back pain. Again, 3 times later, this disc is just burned out. Many ways to skin the cat. I actually love doing lumbar disc replacements. I'm not anterophobic. We all decided this was not a good idea on him. Posterior, nice decompression. The retractors, you can actually see how much retraction we had to do. Nothing much, simple conventional retractors. Nice end plate release with osteotomy, distraction, cage. Post-op day 2, he actually went home today. He was very happy. He could have probably gone home post-op day 1. Yes, he had an extensor spina block. He had no problems. There was no CSF leak or anything like that. Case 2, more complicated. This is a nuclear engineer. We almost needed him Thursday night when a power plant was blown up by our Russian friends, or our control centers, therefore, but I'll curdle my emotions here. The key thing is this is a case of renal osteodystrophy, and this is a 2-level step ladder spondylolisthesis with high-grade stenosis. Again, many ways to try to get to this, but I can tell you any attempt at trying to pry this apart from the front would have probably been pretty hard. Zach Tatarin, who's sitting back here, was with me. This was a very diligent, careful release of nerves, and we did a 2-level IDO and very carefully rebalanced the spine. I think we got a very nice realignment, and the patient is actually quite happy. He did spend a day and a half in the ICU. We did lose 1,100 cc's blood loss. There was no neurologic decline, no dural tear, no CSF leak. And today, he said his back pain is 2 to 3 out of 10, better than it was before. And this is case 3. This is from yesterday. This is a patient with a very complex constellation of circumstances, multiple previous surgeries, including MIS surgeries above, with XLIF above a previous fusion, thoracic laminectomy because she had a junctional kyphosis. Somebody thought this a good idea. She had thoracic myelopathy. She had a forward-pitched posture. We did a very diligent release and osteotomy with a T3 to pelvis fusion, and this patient with not very good bone stock. And this morning, Yev, who was on on call with me, said she looks amazingly good. And here you can see in close-up the IDOs. Yes, we lost, this is not 200, there's a 0 missing, 2,000 cc's per anesthesia, but the surgery itself was anticlimactic. Yes, it took 8 hours. No dural tear. Actually, we had a dural erosion on the left side. We repaired that. 3 units of blood, but she feels great, and everybody's surprised how well she's doing. So these are just a quick panoply of things. I'm not against anterior and anterolateral surgery. I congratulate my wizards here in this audience, and this is truly an all-star collective of people. But again, for me, there's a clear role for those. For instance, tumor or trauma. This is a tumor case. Dr. Oskuyan is a magician. Quick posterior surgery, and then an anterior, actually it's a trauma case, anterior surgery in his hands, and the patient literally walked out of here. So they're very clear cases where anterior and anterolateral surgeries are a breakthrough technology that have changed how I, for instance, do trauma care. But again, with all this cool razzle-dazzle and 3 clicks here and 5 clicks to the back side here, again, sometimes these things go sour, and I still like my old Jeep, especially when the going gets tough. So back to the back. Ladies and gentlemen, please consider it. Thank you.
Hey, Jens, that was great. So when, can you go back to so that one case, that very nice deformity, you did, go back one more.
Oh, he's going to say this.
So I saw that she had 2 hip replacements.
Yeah.
Same point.
What are some things do you try to do? Because there's now she's nice, balanced nicely in the sagittal plane. What are some tricks you use and try to figure out how much correction to do in someone like
That's a great question, because this is my challenge to industry, so I'm looking at all the industry representatives who are watching. I do think that we need a GPS system in surgery, and I think there's several companies, and full disclosure, Rod and I are working on one of those, where we have a much better spatial alignment. Neil knows that also. He's an aficionado of that. We've discussed this. I think there's a real benefit towards having not just my Bovie cord or something like that, but basically I find that with a 2 or 3 level, we're actually prepared for a 3-level IDO on her, but we only needed 2 levels. And again, I think Zach, where's Zach? There he is. What nobody can hear you without a microphone, but you can give us a verbal here in the room. What was your thought when we couldn't open up these disc spaces in the beginning, so what was your thought when it snapped loose? You have to say it loud. This won't project.
It was incredible. I've converted to the power of IDOs now.
Yeah.
Just when she cracked open, the amount of correction was noticeable. A sight to behold.
Yeah, so I mean, this is unprompted, and he could say whatever he wants, and he's a great guy, and he would. But I mean, once you...
How do you crack her open without damaging her end plates?
It's a whole philosophy of IDO. Basically, we do a comprehensive neural decompression. We protect the neural elements very carefully. There's minimal or no retraction. There's protection, but no retraction. We osteotomize off the posterior inferior end plates above and below on either side, imploded. We use a magic tool, the intervertebral distractor that we stole from Sentinel, previously Synthes, for the Protus C, which I think is a magic tool, one of my 10 island tools that I recommend taking with you on the desert island. And we then crack it open bit by bit. This patient would not crack open, so we use very small paddle shavers, starting at 7 millimeters under C-arm, and we very gently tap towards the anterior, towards the lateral plate. We try to avoid going medial until we lift the end plates. We have to remember, and this is for any surgery that we do, the end plates are not end plates. They're a zona compacta, that's compacted cancellous bone. But the actual weight-bearing things are the apophyseal rings on the sides. The center is eminently soft. So as long as we stay in trajectory of our screws, or know that the ring is the real main-bearing thing, and avoid veering off into the center, we have a very good substance to work with. And just gradual, bit by bit, distraction, one side, paddle release, and then change sides.
That's great, yeah. So you don't so for a case like this, because the teaching now is you have to do sacral slope, pelvic incidence, and then do you measure and say, okay, this is how much I'm going to correct?
Not in surgery. I mean, at that point in time, it's a gestalt, and literally the spine is yours. Once you have 2 or 3 level IDOs, literally you can dial in whatever you want, and I mold the rods. That's still, just like you, I love molding rods. We're radical makeover surgeons in that regard, and you literally hold it towards the patient and say, where do I want to go?
And how about how many rods do you use? I only see 2. Why
Yeah,
did
in
you
this one,
only
I
use 2?
thought of possibly using 4, but we felt that given her body mass and the stability of her end plates that we could preserve, we're fine with 2. But you're quite right, and that's a great point. My initial plan actually, and had I done 3, I would have probably done a short compression working rod construct and then a long spanning rod. So you're quite right. Thanks for pointing that out.
Beautiful correction.
Yeah.
Thank you so much.
Jens, beautiful correction, absolutely beautiful. Am I right to say there's ALL division there at those 2 implants?
Oh, completely. Yeah,
right.
completely. Yeah.
And that was all achieved from the back.
Yeah.
Is that right? So in actuality, you are an anterior surgeon. It's just that you approach it from the back, right?
Yeah, no, it's a true 3-column osteotomy.
Right.
There's no question about it. But we try to do it very, very slowly and carefully. We don't put sharp tools around the front. The lateral side we take down with down-biting curettes, and just again between tension and working in a controlled space, we have a reasonable safety to kind of get this release going.
Great.
Well, thanks
so much,
for allowing a
Jens.
reactionary posterior surgeon to speak here.
Yeah, no, that was a great talk. And thanks to all the great speakers that we had today.